And delighted to introduce Dr. Farah Kakso, who is going to introduce our special guest speaker, Dr. Laura Hawks. So, Farah.
Thank you, Dr. Schnapp. I'm really happy to have the opportunity to introduce Dr. Hawks, who is an assistant professor and health equity researcher in the Division of General Internal Medicine at the Medical College of Wisconsin. Dr. Hawks received her BA from Fordham University in the Bronx and also did her medical college at Albert Einstein University, or College of Medicine in the Bronx. She completed internal medicine residency with a focus on primary care at the Yale University School of Medicine. And while at Yale, she worked at the Transitions Clinic, which is a clinic focused specifically on people recently released from incarceration. And she also worked at the Cambridge Healthcare for the Homeless. Following her GIM fellowship, following her residency, she did a GIM fellowship at the Cambridge Health Alliance in Boston, and she simultaneously got an MPH from the Harvard School of Public Health. So not a busy time at all, I'm sure. She ultimately joined MCW in the fall of 2020 and now has her own primary care clinic where she actually does buprenorphine prescribing, which is, not that common everywhere. Dr. Hawks has been studying the intersection of criminal legal involvement and health since she was a medical student, and specifically aims to help patients with diabetes returning from incarceration achieve and maintain control of their illness. Last year, she got a 5-year K23 Career Development Award from NIDDK, which is Diabetes, Digestive, and Kidney, I think I just learned. And it's titled Novel Nurse Case Management to Improve Diabetes Outcomes in Black Men Recently Released from Incarceration. She's been invited to speak internationally on her work to the WHO, which I only mention because my father would love for me to do that, and I have not yet done it, so he'd be very proud of you. And her work has been published many places, including JAMA IM, JGIM, CHEST, Health Equity, and the American Journal of Public Health. Dr. Hawks is truly a leader in studying the impacts of incarceration on health, and I'm so glad you're able to join us today.
All right, how does this sound? Good? Okay, thank you so much, Farah, for that very warm introduction. It is truly an honor to be with you all today. I'm just gonna move, I can move right through to my slides, right? Or does this need to stay up? Yeah, okay. Nope, no, it's not moving. Okay, so well, this talk is going to be slightly different than some of the clinical updates and breaking clinical trials that you often hear in grand rounds. I do hope to bring to you all this morning compelling social argument that's backed with rigorous cutting-edge research and plenty of room for conversation. The title of my talk is Medicine in the Era of Mass Incarceration. So at the end of this session, we'll have covered 3 main topics. The first is a description of mass incarceration in the United States. The second is an analysis of the intersection of the criminal legal system, specifically incarceration, on health, with a particular focus on chronic disease, which is my area of research. And finally, we will examine the novel health risks experienced during the reentry period and how interventions and policies can ameliorate these risks. So it's unlikely the first time you've heard the phrase mass incarceration, or even the first talk you've attended with this topic as a focus. But I'd like to review the history and the current state of the criminal legal system in our country so that we're all on the same page. The United States incarcerates its citizens at a higher rate than any other Western democracy. But it wasn't always this way. As you can see from this slide, oops, sorry. Before the mid-1970s, we really incarcerated citizens at about the same rate as other Western democracies. But beginning in the mid-1970s and expanding rapidly in the 1980s and 90s, the size of the prison population exploded over 600%. So this was largely due to several different reasons. Most commonly cited is the war on drugs, which resulted in increased arrests, longer sentences and stricter sentencing guidelines, and massive expansion of neighborhood police forces in both power and size. A concurrent phenomenon which contributed to the massive influx in our prison population was the deinstitutionalization of the mentally ill, which resulted in the elimination of most publicly funded psychiatric inpatient beds without a concomitant investment in community mental health treatment services. So to date, most Americans with serious mental illness will be housed in carceral settings instead of receiving publicly funded mental health treatment. Of course, a reigning feature of our criminal legal system is the disproportionate burden of criminalization on Black and Brown Americans. This slide depicts the lifetime likelihood of experiencing an imprisonment for US men who were born in 2001. It's estimated that overall, about 1 in 9 American men will experience incarceration in their lifetime. However, that risk is only 1 in 17 for white men, while it is 1 in 3 for Black men who were born in 2001, and 1 in 6 for men who are Latino. Not included in this image, because it wasn't actually included in this data, but has been published elsewhere, is the estimated risk of imprisonment for men who identify as Indigenous or Native American, which is 1 in 2. It's also notable that women are also incarcerated, of course. They are incarcerated at absolute lower rates, but the disparities between the racial groups are similar. It's also worth noting that white American men are far less likely to be incarcerated than their minoritized counterparts, a rate of 1 in 17 is still substantially higher than any other of our peer nations. So this is something that really people of all races are experiencing at high levels and probably higher than any other country. So when we combine our high incarceration rates with the disproportionate incarceration of minoritized groups, layered on top of a setting of pervasive residential racial segregation that persists in all of our country's major metropolitan areas, we have what some scholars have called a phenomenon of hyper-incarceration. A white paper published out of the University of Wisconsin-Milwaukee in 2013 examined this in a Milwaukee area neighborhood, specifically the zip code 53206, which is a near West Side neighborhood, which is 95% Black. The paper received a lot of national attention, and 53206 has since been referred to as the most incarcerated zip code in the country. There's actually a documentary about it. So while this claim itself, in terms of being the most incarcerated zip code, hasn't been fully substantiated, the data presented in the paper are quite stark. So this is that same zip code outlined, and this graph is pulled directly from the paper. Again, this is 53206. The number of dots scattered throughout each represent one person who's been incarcerated in our state's prison system at some point in their life, but are currently living in the community. You'll see that virtually every single block in the zip code has at least one person living on it who's been incarcerated, and is pretty common for blocks to have 5, 10, 15 dots as well. It's estimated that 66% of the men who live in the zip code between the ages of 40 and 50 have been incarcerated at some point in their life. So we don't have time today to go into all of the research showing the cascading effects of an individual's incarceration on the health and livelihood of that person's family and their community. I do hope that this image underscores how deeply disadvantaged a neighborhood will be after experiencing such searing rates of incarceration. And so far, we've actually only covered a small piece of the total correctional pie. On this graph, the number of people who are incarcerated are represented, I haven't quite figured this pointer out yet, are represented through this orange through green pie slices. Representing twice as many people, that nearly 3.5 million people are currently surveilled in community supervision, which is probation and parole. So while probation and parole are largely billed as humane alternatives to incarceration, they actually serve as a net widening apparatus, increasing the prison population through non-criminal probation and parole violations, which are often in addition to increasing your risk for incarceration, substantially curb your ability to meaningfully engage in society through arbitrary and difficult terms of your supervised release. And again, when we consider the impact of our correctional system at the societal level, we have to think beyond incarceration alone. While nearing 2 million people are currently incarcerated, nearly an additional 5 million people have previously spent time in a state or federal prison system, 19 million have a prior felony conviction on their record, and nearly 80 million have a criminal record of some sort. A full 113 million adults, which is over 1/3 of our country's population, have an immediate family member who's ever been to prison or jail. So while we're probably thinking that sitting in this room, you're largely insulated from the reach of the criminal legal system, chances are actually quite good that someone in your near vicinity, or maybe if you're on Zoom, someone in your box right next to you, is actually included in that last group of people, myself included. But we're not here to talk about sociology or criminology, but the population and individual health associations of incarceration. So moving into the next section, we'll talk about incarceration and health, and I consider three major health categories, all of which are important to understand. The first is mental health, the second is substance use disorders, and the third is chronic disease. So just a quick primer on the data presented here. This is anything that is cited as from Lopez et al. Manuscript under review is from a nationally representative survey entitled Survey of Prison Inmates. It's a paper that I am a co-author on. So this survey was distributed within the country's state and federal prisons in 2016, and the outcomes are all based on self-report. So this is the most recent data that we have at the national level about the health conditions of in the prison setting, and it was only actually recently made available to the public. So obviously data that's 6 years old is not new, but it's only been available to the public for about a year. As I mentioned, this is currently under review. It's currently under review at a high impact journal, so I do ask that you not share this data further. Now, that said, mental health conditions are ubiquitous in the prison setting. The survey of prison inmates found that 2 in 5 respondents report a current mental health condition, while 1 in 4 had a chronic mental health condition. And common mental health conditions are highly prevalent, with 25% reporting depression, 21% reporting anxiety, another 21% reporting manic disorders, and 8% reporting a disorder of psychosis. The survey also assessed diagnostically for severe psychologic distress, which was collected by a validated instrument and is defined as mental health problems which cause moderate to severe impairment in social, occupational, or school functioning and require treatment. The study found that over 13% of the respondents to the survey met criteria for severe psychologic distress. By comparison, about 3% of folks in the general population will meet criteria for this condition. I want to take a minute to just talk about a common but particularly harmful exposure that many people experience in prison, just solitary confinement. Solitary confinement, which is also known as SEG, the hole, or isolation, is when individuals are housed alone for 23 hours a day. It's a deeply dehumanizing condition, and the UN standards for treatment of prisoners state that any exposure longer than 14 days is considered cruel and inhumane punishment. However, it's commonplace practice in the United States to keep people in solitary for months, years, and even decades. On top of that, currently in Wisconsin, due to widespread prison staffing shortages, entire prisons are being held on lockdown, which is functionally the same as solitary confinement, for weeks and months at a time. And the data on the health harms of solitary confinement are stark. Exposure to solitary has been causally associated with the deterioration of depression, psychosis, and self-harming behavior. After release, those who are exposed to solitary are more likely to develop new onset PTSD. And more recent studies have actually found an increased risk of mortality after release if you're exposed to solitary, especially due to death by suicide. Of course, substance use disorders are also common in prison and jail settings, which should not come as a surprise because we criminalize drug use in this country like most other Western democracies. The data on this slide, also from the 2016 survey of prison inmates, shows that both alcohol and other drug use disorders are quite common, with about 1/3 of respondents reporting that they were experiencing at least one immediately prior to their incarceration. So we also see high rates of the sequela of substance use, in particular injection drug use, which results in a particular concentration of blood-borne infectious diseases in carceral settings. So the prevalence of HIV is 1.1%, according to the survey of prison inmates, which is 3.7 times higher than the general population. The prevalence of hepatitis C was 7% in that same survey, which is 7 times greater than the general population. The prevalence is also known to vary widely by jurisdiction, with some jail sites documenting prevalence as high as 40%. Of course, prisons were not immune to the recent COVID-19 pandemic. In fact, due to poor ventilation and inability to practice social distancing, many advocates and physicians raised alarm bells early on in the pandemic that the spread of COVID-19 in carceral settings could be quite dire. And unfortunately, these fears largely came to fruition. There were almost about 650,000 cases documented in the prison settings and nearly 3,000 deaths occurring among incarcerated people when they stopped collecting data in July of this year. And data from early in the pandemic showed that the standardized mortality ratio, so the risk of death standardized to age and sex, in carceral settings was 3 times greater within the prisons compared to community settings. So let's shift gears a little bit and talk about the association between incarceration and chronic disease, where the pathway of this association may be slightly less clear. The survey of prison inmates documented that chronic disease is exceedingly common in carceral settings, with nearly 2/3 of respondents reporting at least one condition. The prevalence of hypertension was 28.7%. It's about the same for folks who reported their BMI was greater than 30. 7.1% reported heart disease, 15.9% reported asthma, and a similar amount reported joint disease or arthritis. It's important to remember that this group is actually much younger than the general population, so we would expect to see lower rates of chronic disease. So this chart shows what happens when you standardize the prevalence of disease to age and sex compared to the general population. And there's a notable disparity in the prevalence of chronic disease in carceral versus non-carceral settings, with examples provided here in hypertension, diabetes, and asthma. Specifically, incarceration seems to confer a greater risk of cardiovascular disease. Here, we review data from a nationally representative longitudinal study, which means that this study followed teenagers starting in the 1970s through their 40s and 50s, so that they were able to actually track the development of disease after exposure to incarceration. So even after adjustment for demographic, lifestyle, clinical factors, as well as a broad range of socioeconomic factors, the odds of developing heart disease were 2.2 times greater for those who had a history of incarceration. A separate regional study called the CARDIA study found that incarceration history was associated with a 60% increased odds of developing hypertension. And importantly, this conferred an important clinical risk, which is left ventricular hypertrophy, or a consequence of persistently uncontrolled high blood pressure. This was 2.7 times greater among those with an incarceration history. And unfortunately, the evidence suggests that incarceration also is associated with a greater risk of death. The seminal paper that was published on the high risk of death after release from incarceration was published in the New England Journal in 2007. This study compared the mortality risk for people released from the Washington state prison system during a 4-year study period compared to those who were not released from the prison system during that time. The study found that overall, over the total study period, the cohort released experienced 3.5 times greater risk of death. However, in the 2 weeks immediately following release, that elevated risk of death was 12.7. The leading causes of death were drug overdose, cardiovascular disease, homicide, and suicide. Specifically, the risk of death from cardiovascular disease was over 2 times greater for those released from incarceration than the general population. So what do we know about the quality of and access to medical care for this population with a large and growing burden of disease? Well, historically speaking, and interestingly, incarcerated Americans are actually the only specified population to have guaranteed access to healthcare through the Constitution. So since 1976, when a Supreme Court case called Estelle versus Gamble ruled that the deliberate indifference to the health needs of incarcerated people violates the cruel and unusual punishment clause, which is within the 8th Amendment of the Bill of Rights. However, no subsequent legislation or executive branch efforts have formalized this rights by creating an agency to oversee the healthcare systems in carceral settings. And as a result, there's really a poor understanding of the quality of care in carceral settings, and it likely varies widely. This is in part because there's no body responsible for monitoring it. The National Survey of Prison Inmates did ask a couple of questions about access to care, which I report here. Among those who had at least one chronic physical condition, over 13% reported never having seen a provider during their incarceration. And we excluded anyone who had been incarcerated for less than a year in this sample. Among those with at least one mental health condition, 33% reported having received no treatment since their incarceration. And among those who met criteria for severe psychological distress, 41.7% received no treatment during their incarceration. Finally, for folks who were receiving a mental health pharmacotherapy prior to their incarceration, 34.3% report that therapy had not been continued. Additional information about the quality of healthcare in prisons can be gleaned from isolated court cases that, when taken in sum, suggest that by and large, we fail to provide standard of care treatment across carceral facilities in our country. For example, another federal Supreme Court case from 2011 called Brown versus Plata found that in the state of California, there was a state of severe overcrowding and an inadequate ability to meet the needs of California's carceral population, and that this too violated the 8th Amendment clause, that cruel and unusual punishment clause in the Bill of Rights. As a result of the ruling, the state was forced to decarcerate from 200% operational capacity to 138% of their operational capacity. Notably, 138% is still an overcrowded prison system. The opinion also cited that a preventable death occurred in the prison every 5 to 6 days. So this ruling was issued in 2011. It came 10 years after the case was first brought to the courts. So by my calculation, over 600 people died while waiting for some governmental intervention, not to mention those whose death and morbidity had spurred the court case to begin with. Even more recently, in 2022, a case from the New York State Supreme Court held the New York City Department of Corrections in contempt for failing to provide access to basic medical care in their city jail, which you probably know is Rikers Island. The court filings state that over 8,000 medical visits are missed monthly due to understaffing, and stated that those detained were in grave danger of imminent harm. While the court is in the process of stripping control of the jail from the city, little has changed functionally since May of 22 when this court ruling came down, and at least 19 additional people have died under care at Rikers Island since this ruling was issued. Okay, so far we've covered some heavy stuff. We've covered the state of mass incarceration in our country, the health disparities faced by folks who are incarcerated, evidence that healthcare in our carceral settings is not up to standard of care. My argument over this next section is that we have not yet covered the time period with the gravest risk as it relates to exposure to incarceration, which is release, a medically high-risk time. So you might be thinking to yourself, sure, this junior faculty member, she went to Harvard, she got her MPH. She's telling us that all these people have been incarcerated and, sorry, this keeps doing this, and gone through reentry, and that they're at high risk of morbidity and mortality. But that doesn't mean that incarceration is causing those health outcomes. Indeed, it doesn't require an MPH to identify that there's a number of confounders, which are factors which are associated with both increased likelihood of incarceration as well as increased risk of morbidity and mortality, which could explain, at least in large part, this relationship. Some examples include poverty, access to healthcare, food insecurity, and exposure to violence. And certainly, naming and addressing these structural forms of inequality are deeply important to understanding and solving disparities associated with carceral exposure. However, I'm also hoping to convince you over the next couple of slides that by describing a causal mechanism of action, we can prove that there's a direct effect between incarceration and reentry and morbidity and mortality. And the solutions to these problems are much more attainable. So let's walk through some of the evidence. Studies published since that New England Journal article was published in 2007 have confirmed those findings and actually shed new light into the risks conferred by incarceration, which it appears are actually mostly borne out in the community. So this study examined all people who were incarcerated in the Georgia State prison system on January 1st of 1991, and it compared their risk of death through the study period, which lasted through 2006, so 15 years. Overall, the incarcerated cohort, the standardized mortality ratio was 43%, increased up for folks who were incarcerated at that first study time period. However, when you looked at actually discrete time periods, it turned out that during the time period when folks were actually incarcerated, there was a 15% decrease in their likelihood of death. But then again, if you looked at the time period when they were in the community, there was a 53% increase in their likelihood of death. So this is not to imply that incarceration confers a protective risk or a protective effect, but just that the risks appear to truly be borne out after release to the community. We can understand this mechanism of action a little bit better by understanding particular disease states. So let's start with opioid use disorder, because the pathway here is quite clear. At a population level, individuals with opioid use disorder will have a drop in substance use during incarceration, which leads to a drop in tolerance to opioids. Because medications for the treatment of opioid use disorder are quite rare in carceral settings, we see an unnecessarily high rate of relapse with extraordinarily high rates of overdose death in the time period after release. So there's really a multitude of literature that really confirms these findings that release from prison is an extraordinarily high time to die from an opioid overdose. And this study actually quantified that risk, comparing the standardized mortality ratio for overdose death for those released from prison compared to the general population. And it found that over the study period, which is 1 year in this case, the total risk of death was 10.33 times higher for the population released from prison. However, as you can see from the teal bars on this graph, which is actually an absolute risk of death per 100,000 person years, the risk of death, again, this is only looking at folks who are released from prison, was about 3 times higher in the first week compared to the second, and about 2 times higher in the second week compared to the third, at which point it leveled out. Another condition which highlights the ways that disease control worsens upon release is HIV. In HIV, it's been shown that incarceration is actually associated with improved adherence to antiretroviral therapy, and therefore improved markers of disease control, such as a higher CD4 count and a lower viral load. However, studies out of Connecticut have actually followed folks upon their release from incarceration and found that the CD4 count actually drops with an associated rise in viral load during the reentry period. And the authors of this paper actually found that that was linked to an increased risk of developing an opportunistic infection, as well as developing viral resistance, which both lead to the outcome of morbidity and mortality. An interesting study, this is a little bit of a busy slide, but I think it's worth it to get through it. This actually tracked folks in multiple different settings with HIV through their cascade of care as it pertains to their incarceration exposure. So a cascade of care model tracks the stages required after diagnosis to achieve optimal disease control, which in the case of HIV is a suppressed or undetectable viral load. So the 3 different bars for each of these stages represent those who represent those on the left-hand side in that dark maroon bar who've not been incarcerated. In that middle fuchsia bar, those are folks who are currently incarcerated. In that right-hand magenta bar, we have folks who were previously incarcerated and are now released to the community. So what this study found is that all 3 groups are actually diagnosed with HIV at similar rates, and that the disparities in care seem to emerge at the second step in the cascade, which is linkage to care. And they continue to widen at every step along the way, at which point, until we hit the last step, which is suppressed viral load, at which point those returned to the community have half the likelihood of achieving that step in the cascade compared to those who are currently incarcerated. So there's really, as I mentioned, a lot to take in this slide. Certainly the low levels of viral suppression in all 3 groups is definitely notable. But I'm particularly highlighting that after release, the study documents how patients really fall out of care to levels actually worse than when they were first incarcerated. Finally, our last study examining disease control for chronic non-communicable diseases is for type 1 diabetes. So this study followed the A1C of patients who were incarcerated in the LA County Jail at least twice during the study period. And it found that the average A1C reduced by 10% after folks were first incarcerated and then increased by 14% after release. So that's just visualized here. You can see that folks had an average A1C of 11.5, which dropped to 10 after entry to incarceration, and then popped back up to 11.4 at the time of their second incarceration. So that time in the community, they really lost control of their disease. So understanding the reentry experience is extremely important because virtually everybody, over 95% of people who go into incarceration, will eventually come home. So what is it about reentry that makes it to be such a medically tenuous time? First, patients are released oftentimes with a short 30, 60, sometimes 90-day supply of medication, and then left to figure out medical follow-up on their own. If you have tried to find a PCP for yourself or a loved one in 60 to 90 days, you probably know that this is a steep task, even with good health insurance. Secondly, many folks are uninsured both before and after release. If they have Medicaid, this may actually be disrupted during their incarceration. That said, in Wisconsin, the Department of Corrections, they have programs to help patients enroll in Medicaid prior to release. And we'll actually have some more on this in our talk about solutions. The inherent nature of incarceration when it comes to chronic disease management, people inherently experience substantial barriers to their autonomy, which likely undermines habits that promote self-care behavior, such as medication adherence, maintaining a rigorous diet or exercise routine, and this can all be much harder after release. Additionally, similarly, self-management of chronic disease is often hard and unfamiliar. Remember, this is a young population of folks who are being diagnosed with chronic disease at age earlier than many of their peers. So they may lack peer support in helping to learn how to treat their condition. And finally, most importantly, even after a person has completed their sentence, a criminal record confers a lifetime barriers to the access of the social determinants of health, including employment options, which then limit health insurance options, in addition to housing and other social safety net program limitations. These are often reinforced by a myriad number of laws, discriminatory employer policies, and widespread stigmatization. I did want to mention just one federal policy, which is important to understand as we move into our portion of our talk about solutions. So the series of legislative acts which brought us Medicare and Medicaid in the 1960s included a clause called the Medicaid Inmate Exclusion Policy. So this prohibits federal funds from covering any healthcare costs during incarceration. This means there's no central payer or overseer of the country's carceral healthcare systems, which functionally created a myriad number of siloed correctional healthcare systems across every city, every state in the country. It means that there's no system that's incentivized to improve the long-term health outcomes for patients because they assume that their patients are only going to be under their care for a short, discrete period of time. It also means that there's no clear mechanism of funding for transitional care services, which might help patients plan for care prior to their release from incarceration, in addition to setting up necessary medical, mental health, and addiction clinical appointments. I did also want to just end this section on some evidence for hope. So this study was actually conducted by myself as a lead author and published in the American Journal of Public Health about this time last year. So we looked at the hepatitis C virus treatment cascade for veterans who both had a history and did not have a history of incarceration. So we were actually surprised that we found that there were no statistically significant differences between the two groups at any stage, but particularly the final stage, which is sustained viral resistance, which is functionally treatment cure, disease cure. So we hypothesized why this might be. Again, it was not what we expected to find. So it turns out about 7 years ago, the VHA set out to cure every veteran with hepatitis C in their system. So that means that at baseline, this is a population of folks who have universal access to healthcare. But on top of that, the VHA had set out a number of steps to make treatment access very accessible. The first thing is they issued a very low copay. It only costed about $30 with a sliding scale, but $30 max for an entire course of treatment. They expanded prescribing privileges to include pharmacists and advanced practice prescribers, which is very appropriate for this algorithmic condition. In addition, they minimized treatment requirements, so folks did not have to prove a period of sobriety to be eligible for treatment, nor did they have to undergo the sort of aggressive diagnostic procedures to show that they had an advanced stage of fibrosis. Anybody with a detectable viral load was eligible for treatment. And finally, they met patients where they were at. So they went to homeless shelters, needle exchange programs, and opioid treatment programs to make sure that they were actually finding the patients who might not show up to clinic. So on that somewhat positive note, let's review what we do and we don't know about post-incarceration healthcare innovations. Specifically, what works in post-incarceration care for patients with chronic disease? I'm going to start by talking about some individual level interventions. The first intervention is called the Link-LA intervention, and it examined the effect of a peer health navigator on maintaining viral suppression after release from the LA County Jail. So this navigator was a peer in that they were either formerly incarcerated or had HIV, and in many cases both. Their role was to help bridge incarceration to the community by helping patients follow through on their healthcare engagement, by helping patients follow through with their healthcare appointments. So this was a positive study with 50% of folks in the intervention arm maintaining viral suppression at 1 year compared to 36% in the control, and the P was 0.03. This is actually the sole intervention to be found effective in this particular clinical intervention. There is a study that's underway here at UW for a different intervention. But other interventions that have actually used similar models but didn't incorporate that component of a peer were found to be ineffective. Another peer intervention is called the Post-Incarceration Engagement Program, which is run also by the Veteran Health Affairs Association. This peer support intervention included frequent structured meetings for goal setting and identifying steps to meet these goals. The objective of the program is to keep veterans engaged in primary care and specialty treatment, as well as mental health and addiction services. In addition, they help navigate basic needs such as housing, employment, benefits, legal services, and community-based resources. So this pilot program documented a substantial increase in connection to substance use, mental health, and specialty care. Although interestingly, there was no difference in primary care engagement, but again, the rates were actually high in both groups. In addition, it documented a lower recidivism rate at 7% compared to the state average, which was 11% at 1 year. And 84% of participants were in permanent housing at that 1 year time point. So the third intervention, which you heard a bit about in my introduction, and this one is perhaps the most broad and far-reaching in terms of scale at this point in time, is called the Transitions Clinic Network. This is a model that's originally designed as a primary care home for patients returning to the community. That's centered around a formerly incarcerated community health worker. So this is someone who is now home, formally trained, and usually thriving in their professional space since release. So in their role as a community health worker, they offer basic needs and social services navigation, chronic disease and self-management support, as well as healthcare navigation services. An early randomized control trial showed that those showed decreased emergency department visits among those randomized to the Transitions Clinic arm. And a later quasi-experimental design found reduced incarceration days and probation and parole violations. So a follow-up cost effectiveness analysis actually found that society recouped $2.55 for every dollar spent on a transitions clinic, largely due to the reduction in criminal legal expenses. So there are some limitations of this model, though it's largely a successful one, which include that we don't actually know the specific outcomes on specific clinical conditions. And the model can actually be cumbersome to implement and challenging to reproduce in certain settings. So I'd like to tell you a little bit about the intervention that I'm currently testing under my K-23 Career Development Grant, which you heard a little bit about already. It's called Managed DM. It's a novel nurse case management program to improve diabetes outcomes for Black men recently released from incarceration. So while I would like to return to peer-based interventions in the future, when developing this grant, my team and I actually evaluated what works best in diabetes specifically, especially in marginalized populations, and found that there was one intervention that clearly had the strongest evidence. So this was nurse case management. Nurse case management is a collaborative relationship between nurse and patients in which they assess a plan and implement services required to meet the patient's health and human service needs. A meta-analysis of nurse case management interventions in low-income populations found a nearly 1% reduction in average A1C. So as a prescriber and the individual level, that might not seem like a very impressive reduction, but actually at the population level, that is quite high. So for comparison, the blockbuster anti-glycemic medication semaglutide or Ozempic, the average A1C in Ozempic studies, the average A1C reduction is about 1.5%, and that's for a blockbuster medication. For empagliflozin, which also recently has been dubbed a first-line medication in the treatment of type 2 diabetes, the reduction is about 0.8%. So nurse case management is a highly effective non-pharmacologic intervention. Our nurse case management intervention will have 3 components: diabetes education, healthcare navigation, and basic needs navigation. So the basic needs navigation is really is tailoring to the needs of folks with criminal legal involvement. It's not oftentimes standard part of nurse case management, plus a component of cultural competency. So we'll have this, we've designed this intervention to be detached from a specific clinic. So it's not gonna be embedded in a primary care clinic. And we're gonna be recruiting from community-based sites, including churches, community clinics, FQHCs, as well as reentry programs. We plan to enroll 100 men. We hope to start enrollment next month within 12 months of release from prison in Milwaukee, Kenosha, and Racine counties. And we'll test the intervention's effects on A1C as a primary outcome, blood pressure control, LDL, and smoking cessation as secondary clinical outcomes, and healthcare utilization and criminal legal involvement measures as exploratory outcomes. So finally, I'd like to just cover a few policy interventions which have documented success in this field. I'd be remiss not to highlight this really clever study by a team from here at the University of Wisconsin, which was led by Marguerite Burns. They looked at the percentage of individuals released from our state prison system who were enrolled in Medicaid in 1 month after release. And then they examined 2 different policy interventions and how those changed the likelihood of enrollment or the prevalence of enrollment. So you can see that before Medicaid expansion, so in 2014, we expanded Medicaid eligibility requirements, and that change alone resulted in an increase from about 10% of folks released from prison having Medicaid to about 40% of folks released from prison to have Medicaid. But that wasn't enough. A lot of folks who were eligible weren't actually getting enrolled. So the Department of Corrections initiated a enrollment assistance program, and they actually found that resulted in another 30% increase, such that by the end of the study period, about 70% of folks returning from prisons were enrolled in Medicaid at time of release. So in sum, these 2 policy interventions really increased enrollment in Medicaid from about 10% to about 70%, which is really a stark improvement. They also studied the effect of enrollment services among patients with substance use disorder. So they did a follow-up study to actually see how this improved enrollment in Medicaid resulted in improved engagement in care. They found there was a 7.6% increase in total outpatient service use, and there was a small, about 1% or less, but significant increase in outpatient visits with an opioid use disorder diagnosis or substance use disorder diagnosis, as well as an increase in receipt of medications for opioid use disorder. So that leads me nicely into a policy intervention, which is likely the single most impactful, lowest of the lowest hanging fruit to reduce mortality after release from prison. And that's simply to offer medications to treat opioid use disorder during incarceration, specifically methadone and buprenorphine. So as I mentioned previously, access to these medications is extraordinarily rare in prisons and jails around our country. Some Wisconsin jails, including in Milwaukee, but I do not believe here in Dane County, do offer buprenorphine. But for anyone who's then transferred to the prison system, they're forced to go through withdrawal because we do not offer buprenorphine or methadone in the prison system. However, data on what happens when you actually offer those medications are really impressive. So it comes out of the New York City jail system, which started offering buprenorphine and methadone in 2011. And it followed what happened to folks who received with opioid use disorder, who received the medications versus those who did not. So this is a survival curve all the way over there on your left. It showed an 80% reduction in overdose mortality at 1 month post-release. So if you're not a health services researcher, you might not know that an 80% reduction in mortality is practically unheard of. And I don't include it on this slide, but Massachusetts has recently started rolling out the process of introducing buprenorphine and methadone across their prisons across the state, which leads for a nice opportunity to do some natural experiments comparing outcomes for folks released to prisons that have versus haven't started it. And they really confirm these findings in addition to showing remarkable reductions in recidivism and other important societal outcomes. And finally, they show that it's safe and effective to provide these medications in the prisons, which tend to be the number one reason why folks are resistant. So as a physician or a provider practicing medicine in the era of mass incarceration, what can you specifically do? You might not be planning to change your career trajectory based on this talk. There are a lot of learners in the room, so just maybe, but I would like to offer some small actionable changes that you can make. The first is to recognize incarceration history, and especially the reentry period, as a high-risk, health-harming exposure. I encourage you to discuss this experience with your patients in a non-judgmental way, but aligned with their comfort. So I usually ask if they want to talk about it. If they say no, I respect that. I encourage you to support policies which enhance transitional care services after release and also overall reduce our reliance on the criminal legal system. And finally, based off the available evidence, realize the potential of individuals with lived experience as the center of future solutions. So to conclude, I want to include one final policy measure I'd like you to know about. This is a federal policy which is currently proposed in both houses of Congress with bipartisan support called the Medicaid Reentry Act. The act recently introduced in in the Senate was actually introduced with our own Senator Tammy Baldwin as a co-sponsor. As I mentioned, there's a federal policy on the books called the Medicaid Inmate Exclusion Policy, which prohibits federal funds from covering healthcare costs during incarceration. So the Medicaid Reentry Act would allow Medicaid to cover medical services during that last portion of incarceration. The time in the bills varies between 30 and 90 days. So while this would probably improve enrollment in Medicaid, it wouldn't actually improve eligibility for Medicaid. It would be largely beneficial for the purposes of providing a mechanism for funding those transitional healthcare services, which could really aid healthcare during that reentry period. There may also be some unintended benefits for problems I alluded to earlier in the talk, including implementing rigorous data and monitoring and reporting, which currently is absent across our carceral healthcare facilities, as well as mandating a standard of care as being part of the Medicaid program. So with that, I'll conclude. I thank you all so much for your attention today and for having me. I hope that you've learned a little bit of something about mass incarceration in the United States, about how incarceration and health intersect, and about the novel health risks of reentry and what we can do to improve them. So I thank you all. My email is up there if you have any questions. I'd like to acknowledge my career mentors, Dr. Wong, McCormick, and Ageti, as well as my family. They're in Milwaukee right now, and they're incredibly supportive of me.
Thank you. As somebody who studies this all the time, I learned a lot, so I hope everybody else did. Dr. Schnapp is going to look at the online for questions, and I'll do questions in the room. I have one to start, if that's okay. You mentioned that you are going to do your intervention detached from a specific clinic, and I wondered why you chose that and what you found were the benefits and drawbacks of putting the nurse in a specific clinic.
Yeah, so I think that a lot of the models that already exist are based in that primary care clinic model, and it's really important to have that where you have that actual primary care home that patients can go and have that comprehensive care. But in that model, which is one, hard to build up, and two, it's harder to catch people who aren't going to show up to clinic in that way. So having an additional intervention which can meet people in the community and bring them in an alternative way, and not in that sort of traditional, you have to show up to our clinic and then we'll treat you model. Again, not to say that that model isn't important, but that the two models combined might actually get more people into care.
Hey, a couple of questions from the audience. One is asking about vitamin levels in incarcerated populations, specifically vitamin B6, because of its importance for serotonin and other neurotransmitter synthesis. Are you aware of any data?
That is a great question. I have never seen a study on vitamin levels for folks who are incarcerated. Not to say that it doesn't exist, but I am not familiar with it. It would not surprise me. Obviously, I imagine vitamin D levels have to be low, but certainly it would be an interesting study to conduct.
And then what are the barriers for getting opioid use disorder treatment in the implemented at the local jail level? And is that something feasible in Dane County? And
Yeah.
are there
Great
programs?
question. So the main barriers are put up by usually non-medical correctional leaders. Usually, sometimes medical correctional leaders also oppose. There tends to be a pretty strong fear of diversion and creating a black market, which is not completely unfounded. It's very common for folks to manipulate the way that they take their medications in any sort of forced treatment environment, including corrections. I think the argument against that, especially for buprenorphine, is that if you treated anybody with opioid use disorder with buprenorphine, if they wanted it, then there would be no black market because it would be available to anybody who wanted it. It's not, not to say that people couldn't somehow manipulate that as well, but it's a very, very safe medication. Methadone has a few more risks in terms of potential overdose, but buprenorphine is just so extraordinarily safe, and really the evidence that it reduces harm is much greater than that it causes harm. So the evidence for limiting access to buprenorphine, or the arguments, in my opinion, are quite limited. But that doesn't stop, stigma from sort of reigning. I have talked to the correctional leaders in the Milwaukee County jails that offer them, and I know there's been talks in Dane County to start offering buprenorphine. I'm pretty sure like the same correctional healthcare organization is WellPath. So it's not about the actual healthcare organization because they were providing it in Milwaukee and not in Dane County. I'm not sure what the specific barriers are here in Dane County.
And every prison system, jail system is separate, so it's not.
So sorry. Every single, there's one state prison system, which about 20 prisons, and about 20,000 people incarcerated. But every single county has their own jail. And they're all managed separately. So there's no universal body that manages the healthcare systems for every jail in the state. And so it has to be made really at that individual level. And it's a little surprising how much power non-medical people have over this particular issue. I know that at the MSDF, which is actually part of the prison system, but it's more like a jail, it's in Milwaukee. They've received a grant from SAMHSA to start prescribing or providing buprenorphine, and the warden has sort of single-handedly put up a lot of barriers to actually getting, so they have the money and the resources to actually implement it, but they haven't actually gotten it rolled out yet because of barriers put up by the correctional staff. Yes.
Yeah, I think that was fantastic.
Yeah.
Hi, Ed Vasilevskis. I'm the division chief for hospital medicine. I have a twofer for you.
Yeah.
One question has to do about one of the risks. You mentioned that the population tends to be younger. My understanding is there's a much larger growing population of older patients.
Yes.
And wondering about the independent risk factor of incarceration with dementia or cognitive impairment. So that's one. Two is, as a hospitalist, what do you see as the opportunities for us in hospital medicine to intervene and be potentially a point entry for kind of helping with some of these long-term issues and transitions?
Yeah, so great questions. I think we're seeing that there's mounting studies that are being published about healthcare among older incarcerated people. Again, with these long prison sentences combined with, about 20 to 30 years ago, like there was tons of people who were incarcerated with extremely long prison sentences, and that population is now getting quite old. In addition to the fact that older people are also becoming incarcerated newly, we do see really growing rates of older folks in carceral settings. And I have to admit, I do not remember off the top of my head all of the associations, but certainly we see higher rates of like physical and mental disability, which would certainly include cognitive impairment and also ability to get around and sort of be independently functional in the carceral setting, which you can imagine is quite a big deal if you can't care for yourself and you don't have that sort of support around you. Dr. Casco might have a better answer because I know her specialty is caring for folks who are hospitalized and incarcerated. I would just say one thing that I think about a lot is how we give a lot of deference to the criminal legal operators when they're in the hospital for understandable reasons. But actually there still is a mandate to support patient privacy, and that it's sort of okay to put yourself as the healthcare provider out there and say, I really need a time alone with the patient, and sort of insist on having that time to interview the patient in privacy if that's what they want, and having moments alone with the patient without their correctional officer or in the room with them, which takes a little bit of bravery, but my understanding is that we have the sort of authority to do that. Yeah.
Thank you so much. So I kind of have two questions. One is like from the actual prison system administration, what the incentive is for them to improve their chronic comorbidities of the patients themselves. From our perspective, it's great, but if there's actual reasons for them to really want to improve it. And then the other part is there's a lot more privatization of prison systems. And so I'm curious if you've seen any data come out on how their health changes at that point.
Yeah. So, the argument that I hoped that I tried to build is that because of the way that we fund our prison systems, and like we just talked about, there's individual jails, they are all managed and funded differently. Every state has their own system. There's one federal system, but that's about 10% of the total prison population. It's relatively low. Yeah, the total prison population. So it's the greatest number of any one system, but it's still relatively low. Is that it's really hard to incentivize the the people who manage those resources, long-term healthcare outcomes because of the way that we've siloed them, that oftentimes, even if folks are incarcerated for a long period of time, they're going to be moving from jail to jail to jail, for prison to prison to prison. So, you know, they're not under any one person's care for a prolonged period of time. And that really is a problem. Although, you know, certainly some really well-run systems have been able to prioritize long-term health outcomes, some really creative solutions. I probably don't have time to go into now for getting hepatitis C treatment into jail or into prisons in some states have been really effective. And there's really strong arguments that if we actually want to substantially reduce the population burden of hepatitis C in the country, we have to treat people who are incarcerated. And of course, it's feasible from a technical standpoint, but getting that sort of cost component into it is important. So yeah, so I think, and that's why I'd like to think that bringing Medicaid into the prison systems, even if it's just that for that last chunk of time, it might at least push us in the direction of thinking about more long-term healthcare outcomes. And then you had another question that I can't remember right now. Oh, privatization. Yeah. So, so there's two ways that hospitals can be, that prisons can be privatized. They can actually be, the entire prison itself can be privatized, or the healthcare within the system can be privatized. So by and large, the most common way that we see privatization is in the healthcare system. I think it's about 8% of all the prisons in the country are completely privatized, if that makes sense. And certainly there's a lot of horrific stories about what happens when you privatize prisons because of sort of the incentive to improve profits. The data actually is sort of interesting from like an actual risk of mortality in the prison setting. It seems to actually be lower in the prisons, the whole system that's privatized. And that might be because they're selecting patients that are healthier. And it might also be that they have much stronger security measures. So we're seeing reduction in accidental deaths and homicides and suicides, which are actually the most common reasons that people die while they're incarcerated. And there's actually not a lot of data. It's hard to tell from the population, or to look at, from using data at the national scale, finding out which hospitals have privatized healthcare systems and comparing outcomes. There's just really no way to do that. So it's hard to say. But certainly there's been a lot of horror stories, although, you know, the New York City jail is in a mess right now, and they're publicly run, and they stripped away the care from the privatized healthcare provider about 10 years ago, and it clearly hasn't gotten better. So, I mean, I think that it's kind of a mess, no matter who the manager is.
Another question, you mentioned people get moved from jail to jail. Can you comment about electronic medical records and tracking their healthcare, or
Great question. 'Cause
inability to do that?
that's a huge problem when we think about the siloing of health records is, again, so every state's going to have their own EMR. And I actually don't know how it works from transferring from prison to prison or jail to jail, like how those records. I suspect that at least the statewide prison system has one universal EMR. So they do have, although a lot of times they're going to be sent out to hospitals, and then they're going to have, you know, for care. So, so the long and short of it is there's a huge problem with medical records for folks who are incarcerated, because first, returning back to the community, you've lost, if you were incarcerated for 15, I have a patient who was incarcerated for 15 years. I have no idea what happened to him. I haven't been able to get the records. And so it's like, well, I just, you know, do the best of what I have in front of me, and he's doing fine. But, you know, it's like, that's information you'd like to have as a primary care doctor. And so, yeah, so, you know, medical records, again, are not easy no matter what part of the healthcare system you're in, carceral or not. But certainly the extra barrier to getting records between the community and the correctional healthcare records is a big, big problem.
And then finally, you mentioned peer facilitated interventions seem to be effective. What is it about the peer component of it that you think is adding to the effectiveness?
I think there's sort of two parts. The first is when you're bringing the patients into care, they've had really bad experiences with healthcare across their life course, especially probably most recently with their carceral exposure, but on average, healthcare probably has not been as welcoming to this population. And so having a familiar face, someone who can really connect with them very naturally and organically is a great way to build trust a little bit more quickly. And having someone who can kind of vouch for you as a provider and your team and say, these are other patients that have done really well can be a really good place, a way to make people feel comfortable when they actually come into clinic. I think that there's also something very unique about putting people with lived experience in the center of the solution because they help to create the solutions. So they're going to actually make changes to the clinic, to your plan, to the long-term vision of your clinic that you maybe wouldn't have thought about. And so therefore, it might be subtle things like, I don't know, like something about the waiting room or how long patients are actually in the room. Maybe they should be in the room longer, or maybe they should be in the room shorter. Maybe, like learning about how people might be more, reluctant to have the door closed or something like that. Little things that you might learn about that you really wouldn't have any sort of idea to change in your own practice if you didn't have someone that was comfortable telling you their own experience.
Thank you so much again, Dr. Hawks. Dr. Hawks will be here for a few more minutes if anyone has other questions, but we'll say goodbye to the people online.